presentation is about implementing PRISM into Oklahoma City's population of individuals who are experiencing homelessness and mental illness. A little bit of background about Oklahoma City. A 2023 survey identified approximately 1,436 individuals who were experiencing homelessness in Oklahoma City, recognizing that this is a hard population to get some specific data on. This number could be a lot higher than what we expect, but this was a point in time survey done and the data we currently have. Of those 1,400 individuals, 23% of the survey respondents reported some type of mental illness, which is approximately 330 individuals from this survey. The individuals that were in this demographic were primarily male, with about 62% male, 36% female, 1% non-conforming, and 1% transgender. They're primarily Caucasian or African American, but we're also represented by Native American, those who identify as 2 or more races, and also Native Hawaiian or Pacific Islander. Some background on PRISM. It is an evidence-based program that was piloted in Montreal. The word PRISM is actually from this French saying. It is heavily reliant on community partnership, and it requires a significant amount of community involvement. And it is goal focused, both short-term and long-term goals. The reason for identifying mental health as a target for this population is because homelessness is both a social and a health issue. Studies suggest that some psychologically informed environments are key to mitigating a variety of mental health issues, and encouraging an environment that looks at the whole person instead of just their environment and that effect on their health outcome is going to be important for ending homelessness in certain individuals. For the program model, we're going to start with our situation, which are those individuals who are unable to find housing solutions because of interfering mental health crises. They're not able to receive care due to costs, and as a result are chronically unhoused. Some inputs are going to be people, time, money, partnerships, and relationships with healthcare stakeholders for referral to programs. So specifically there with healthcare stakeholders, it's going to be those who are seeing individuals who are unhoused and could benefit from this program based on the qualifications. So the program activities will be to recruit participants, having some training for appropriate staff roles, collaboration with those stakeholders and events, some key psychiatric services, individualized case management, and facilitate meeting with policymakers. So for participation, we're going to need some short-term homeless shelters, so some shelters that are willing to house individuals for the short-term aspect of the plan, which is going to be about 2 to 3 months. Persons with severe mental illness who are experiencing homelessness, and family members of those participants, as well as healthcare professionals and policymakers. The outputs are we're going to have trained staff and volunteers for case management, quick access to shelter and psychiatric care for participants who are experiencing a crisis, and then overall reduction of persons experiencing homelessness. For our outcomes, our participants will complete a 2 to 3 month stay under a case management with a routine psychiatric care. And then for those intermediate times, we're going to have active involvement in that psychiatric care. And then for our long-term goals, it's going to be ending the chronic unhoused nature of each individual and having a plan with a case manager to continue that psychiatric care beyond the program's duration. Participants who are going to enroll in the program will start at enrollment. They'll be assigned a case manager, and they will be placed in a short-term housing at participating community shelters. This is going to be a place that they for sure have a place to stay every night for 2 to 3 months. While that is going on, they are also participating in routine psychiatric care. They're seeing their psychologist. They are being treated for their mental illness. And then while that's going on in the background, the case manager is working on facilitating some long-term housing. So they've enrolled, we're in this housing situation, and then quickly transitioning to long-term housing. So fixing both issues at once, since it is very systemic in nature. And then the final stage is going to be participants are able to engage with other individuals who are in that situation. We're going to provide forums and some really important weekly sessions that's going to allow people who are in different parts of the program to communicate and network and understand the different aspects that go into mental illness and homelessness and provide that type of community there. Our goal, so our primary goal is to have 10 participants enrolled within the program's first year, the pilot year in Oklahoma City. Intermediate goals is to retain 75% of those participants in long-term housing solutions, recognizing that some individuals will either elect to discontinue to participate in the program or move or all sorts of different situations. And then fully expand that to 20 participants in year 2. Indicators of effectiveness. So how often do participants utilize the transportation methods? So once individuals are in long-term housing solutions, they're going to be given transportation to the shelter that they originally had stayed at to receive that psychiatric care and that continuum of care. If transportation does prove to be an issue, then prison will provide bus passes, will provide ride share passes, or any type of transportation to allow them to remove that barrier from treatment. And so evaluating how that transportation aspect affects appointment attendance is going to be one indicator of effectiveness. A second indicator of effectiveness is going to be how often people are participating in the voluntary sessions. So the weekly group sessions that are going to be for individuals at different parts of their journey in the program. So those individuals are going to be able to elect to participate in those. This will be outside of the psychiatric care. And so how do those group sessions and the networking that goes on there affect the longevity of those housing solutions? How for individuals who are then transferred into their long-term housing solutions, how are they able to use that network to maintain healthy choices? And then, of course, we're going to look at the effect of the program services and increasing housing for longevity of participants in general. As far as the budget goes, for the $300,000 budget that's allocated, 79% of that budget is going to go to staff, which is a large portion. Of course, a full-time employee, which is going to be the caseworker. And then we're going to have a part-time program manager. So this will be someone who also has multiple programs that they're managing. They're going to be able to help facilitate the logistics of this program and the grant requirements. And then prison will pay for up to 10% of a part-time employee for us, but a psychiatrist who is already employed at one of the shelters to be able to see our patients as well. The other 21% of the budget is going to go to travel and supplies. So that full-time employee will be expected to travel quite a bit. And so we will be able to reimburse them. And then also for